I think there's a masterclass. There's much to learn from. There's a question in the chat here that points to, how can we implement this? But I think you've answered that question very well. And I think I direct that participant to the chapters of the Kira mentioned, which is really how to. It's complemented also by the framework of meaningful engagement, which sits squarely within the specificity of those with lived experience of health conditions. It's a subset of the broader social participation ecosystem. But very important there. You also find some how-to and some of the guiding principles and actions that can be taken. So I think that's an excellent and it's a nice segue to our next panelist. Thank you, Kira. I welcome Beatrice Vetter, Director for NCDs at FIND. This does have much relevance to our previous discussion. We will now discuss sort of the access to diagnostics and sort of how we can unpackage some of the bottlenecks there, which are really driving the pain, the suffering, the premature mortality of those living with NCDs. So the question is sort of clear. Is it right to say that the lack of early and timely diagnostics and frequent monitoring are among the main bottlenecks to achieving SDG 3.4 and delivering better responses to those on the ground? With you.
Thank you. Thank you, Guy, and thank you, Forum CCNT and Mark, for giving me the opportunity to address a little bit the dire lack in access to early diagnostics and monitoring for non-communicable diseases. So my name is Beatrice Vetter, and I'm the director of the NCD program here at FIND. I'm based in Switzerland. FIND is an international NGO working to address the lack or equitable access to diagnostics worldwide. We work in different disease areas, of course, infectious diseases, as well as non-communicable diseases, about which we will talk just now. So as Guy just mentioned, so the question really is here for the next 10-15 minutes to reflect a little bit on saying, is it right to say that the lack of early and timely diagnosis and frequent monitoring are among the main barriers to achieving SDG 3? And I want to take you through a few examples as well as some background information in general on where are we today with access to diagnostics and what opportunities are there to overcome some of the barriers that we are seeing. So here's the situation. So this graph was published in the Lancet Commission on Diagnostics in 2021. And it shows you the care cascade for diabetes and hypertension. So you can see number of all people living with either of those two conditions, number of people screened at a screening event, then number of people receiving a confirmed diagnosis, number of people treated, and number of people controlled or treatment completed. I think we'll probably say successfully enrolled in care and staying in care. And as you can see, the situation is quite dire. So less than 50% of people with diabetes or hypertension are diagnosed, while a few more receive initial screening tests. There is a gap in drop-off between screening and confirmed diagnosis, and fewer than 1 in 4 people are successfully treated. So really, what the Lancet Commission then said, okay, what if we were to increase these numbers to 90%? How much impact would it actually have on death avoided and disability-adjusted life years gained or averted? So by increasing the number of people diagnosed to 90%, an estimated 0.6 million deaths could be avoided and 14.7 million DALYs averted annually. And I think it's the DALYs that are so critical for NCDs, because of course one can live with an NCD, but with chronic complications and frequent disabilities and inabilities to work, that is a massive amount of lost lifetime, lost quality of life, as well as lost workforce to any country or community. So yes, the lack of diagnostics and monitoring are key, if not the only ones, barriers to achieving SDG 3.4 based on these data. So what can we do to close this diagnostic gap, to get closer to the 90 rather than what we see now, the less than 50%? I want to talk today about 3 principal approaches. One is bringing testing closer to the community through point-of-care technologies and self-testing. Two is integrate testing into other health initiatives, because of course we know NCDs often, take a long time before they present with symptoms, whereas acute infections, for example, or other health concerns motivate people to seek healthcare, and that's an opportunity to engage with them around any underlying non-diagnosed NCD. And of course, also we must strengthen the linkage to care. And I will show you an example how critical it is to actually also achieve good enrollment in care and treatment, and what the gap is for the linkage. So just a brief sort of technical slide, right? When we talk about point of care and self-testing in the example of diabetes and hypertension, what are we actually talking about? What kind of technologies are we talking about that we need to make sure people have access to? So when we look at self-testing, which is critically important for people living with chronic conditions, because someone with a chronic condition spends 95% of their lifetime at home managing their own condition, and only 5% with a healthcare provider. So the very basic self-testing tools are, of course, blood pressure monitors that can be used at home, blood glucose meters as a traditional tool to check blood sugar for diabetes, and then the newer technologies for diabetes management, such as the continuous glucose monitors. These are not so much topic of my presentation today, but I want to highlight them because they are so critical, particularly when it comes to monitoring. And we know that many people are not able to self-monitor strongly at home because the commodities are expensive and frequently not provided well through government schemes. When we look at community testing, so this is sort of outside structured health facilities, but taking the products and the technologies into the community. Of course, again, we have the blood pressure monitors that can be used by healthcare providers, community health workers, anyone who is engaging in health community screening events. Blood glucose meters and test strip can easily be taken in the community. And then there are portable devices. Here's the example for the glycated hemoglobin device, which is often also used in diabetes screening. So these are quite easily and portable to take to the community. And then we can look at the primary healthcare level, which of course is so critical as a first point of call for people when they maybe had an elevated screening result or they have another health concern. And here the technologies can be a little bit more stationary. So we have slightly larger devices for glycated hemoglobin that sit on a table. We also have cardiometabolic point of care devices. So these are useful because they can test for multiple parameters, like your cholesterol, creatinine, the glucose also, and the glycemic index, as well as maybe other cardiovascular disease markers. Yet they are still small enough to be used in a facility that does not have high infrastructure and laboratories. Of course, the blood pressure monitors are used in primary healthcare, as well as, again, the blood glucose meter as a technology. So with this in mind, we actually started to ask some questions on implementation. Does it actually work? Sort of what can these technologies for point of care testing do to improve diagnostic rates? And do they actually improve diagnostic rates? So we partnered with Chronicas, an affiliate of the University of Peru, and basically asked the question, will point of care testing improve diagnostic rates compared to standard of care external lab testing? Because of course, today, we know that often even when someone seeks care in a primary healthcare facility, they get a venous blood sample taken, which will then need to be sent to the laboratory, which will then have a certain turnaround time for results. And there is a high risk of loss to follow-up. Or maybe the patient needs to get the result before they come to the healthcare facility, and then plan this ahead, and there will be costs incurred, which can also stop them from actually getting these. So what we did was we looked at implementation of multi-parameter point of care devices for NCDs at primary healthcare level in urban and rural areas of Peru. And this is an example of the device. And again, it tests for lipids like the cholesterol, creatinine for kidney disease, as well as diabetes through glucose and glycated hemoglobin. And the results really showed that, as an example, in diabetes, how many new diagnoses of diabetes did we get with using point of care at primary healthcare in comparison to lab-based results. The patients were always received at the primary healthcare facility, but in one arm, they were receiving a test there and then with a healthcare provider. And in the second facility, they would go through the standard testing, taking a venous blood sample, sent to the laboratory. And what we found is that 13.3% of people were newly diagnosed at the primary healthcare level when a point of care test was available. And actually half of that, 7.6% of people were newly diagnosed at PHC, primary healthcare level, when only standard of care external lab testing was. So basically twice as many people were newly diagnosed with diabetes when a point of care device was present. And the effect was particularly strong in the rural areas. And of course, it's not difficult to see why that is, because in the rural areas, access to the external centralized laboratories is even more difficult, sample turnaround time is much longer, and the loss to follow-up is high. So point of care testing can reach more people and provide a diagnosis during the consultation, avoiding loss to follow-up. Because of course, these devices, the way they work is that the patient gets their finger pricked. There is a small sample collection device that goes into the testing machine as shown here. And within 10-15 minutes, the result is available. So basically the patient can wait while doing this. So not only can these be placed in primary care facilities, but the result turnaround is much quicker. So this is very promising in terms of a result, that point of care testing technologies are a way to close the diagnostic gap that we've seen before. Now I want to give you an example about integrated testing. So the second solution I proposed previously was to say there are health drive efforts where people seek healthcare for other reasons. So here, is this an opportunity to integrate screening and testing, for example, diabetes, as well as, say, hypertension? So what we did during COVID-19, where of course a lot of people were motivated to seek health and healthcare, is that we said, let's try integrating of NCD screening into public health center COVID-19 vaccination efforts. And this study was conducted in South Africa. So a lot of people went to a specific center to get their COVID vaccine. And we wanted to evaluate the feasibility, yield, and linkage to onboard care of rapid screening for diabetes and hypertension alongside an existing COVID-19 vaccination program. And importantly, we also wanted to assess the total cost, because of course, it's one thing about showing that it works. The next question from any implementer or policymaker will be, well, how much does it actually cost me? So we had a study population of over 1,300 people attending a public health facility obtaining a COVID vaccination. And overall, we found that the diabetes prevalence was 4.1%. The hypertension prevalence was 19.1%. And importantly, the potentially newly diagnosed was 7.8%. Because some people attend the facility and they already are aware that they have hypertension or diabetes. So the number of newly diagnosed in that sort of effort is really quite critical in order to estimate cost effectiveness. And when we look at costs, so the median cost per person screened for NCDs was $1.7. So that is very low, but of course, many people will be not at risk of, they will be with good blood pressure and low glucose levels. So it is really important to know what is the cumulative cost per each new case found. So for each potentially new case found, it was for diabetes was just under $290 because of the slightly lower prevalence of 4.1%. And the cost for finding a potential new case of hypertension was $36 because the prevalence of hypertension was actually quite high. So this is really important to understand, then put it into context. How much does, say, a government or a provincial government need to invest in order to find someone who is not yet diagnosed, but at risk of potentially having hypertension or diabetes? So understanding the yield and cost of screening and case identification in unrelated health activities, so unrelated to NCDs, is an essential first step in understanding the feasibility and resource requirement for such initiatives. And with that, I want to take you to the next example. So the previous example was where people actually went to a healthcare facility because they had a health-related concern. In this case, they wanted to get a COVID vaccine. Now, of course, there are also community testing examples. Once more, COVID-19 gave us an opportunity to test integration of NCD screening into COVID-19 testing at taxi ranks in South Africa. So the taxi ranks, a little bit like illustrated in this picture here, are places where people go in the morning to catch one of those white minibuses to go to work. And during COVID-19, there was a service on offer to say, if you have any symptoms or you just want to double check, then you can get your COVID test here for free. So we said, okay, great. Anyone who would like to get that COVID test, we can also test them for hypertension and diabetes. And this was done in a population of just under 1,200 people at this public taxi rank. And what we found here was a diabetes prevalence of 7.1% and a hypertension prevalence of 27.9%, so slightly higher than what we saw in the vaccination study. And the potentially new diagnosed critically was 22%, which is, an astonishing result to think that there were 20% of people who were found with elevated glucose levels, blood sugar levels, and elevated blood pressure, but they had no idea that they potentially have a non-communicable disease. However, then, of course, because it was a study context, we looked at linkage to care. And as you can see, linkage to care had massive gaps, right? So the diabetes rate of linkage to care was only at 16.3%. So out of all people who were tested with an elevated glucose level, only 16.3% managed to go to a follow-up in a healthcare facility, because, of course, that is what happens after the screening. And for hypertension, the linkage to care was around 30%. And you may remember from my first graph that there's 100% of the population, and the first step is the screening, and the second one was only the diagnosis. So here we look at the screening. Well, yes, people get screened and they get identified as being at risk, but because the linkage to care gap is quite big, the drop-off to receiving a confirmed diagnosis is quite high. So the screening approach demonstrates the value to integrated NCD testing opportunistically, because we identified many with a potential new diagnosis, 22%, in this NCD unrelated health activity. However, linkage to care must be strengthened for screening outside of health facilities to make the approach feasible. There's no costing component to this study, but I think this is something very important for follow-up activity after this. So really, if we think about what needs to change, I think in summary, it's really testing needs to move closer to the point of care to increase coverage and reduce the risk of loss to follow-up. Of course, today we know that point of care testing in public sector facilities is implemented in a fragmented manner. It's mostly at provincial level, and depending on the country, there are pilot projects of bringing, for example, HbA1c or glycated hemoglobin testing to the point of care under the national testing strategies. There's such demonstration example just happening in South Africa at the moment, where data are gathered, products are being procured nationally or subnationally, and then installed in facilities, and data are now being gathered about their uptake and the use of it. But it's often not done at a national level because there are many barriers to consider first for the governments to switch or improve testing from the centralized laboratory to the point of care. We also really need to integrate testing into other health initiatives. And this is so important to me to demonstrate, because for sure, other health concerns will come along, right? I mean, of course, we have the epidemic health concerns like we see during COVID-19, and we may have other such respiratory condition outbreaks. But of course, we also have the regular testing facilities, for example, for tuberculosis or the HIV programs, where sometimes testing integration for NCDs is done, but it is not a routine activity to be included in all programs. And as such, we really need strong data to demonstrate that this is a feasible approach. Strengthening linkage to care is critical to make new testing approaches for early diagnosis feasible. There are initial examples to encourage linkage to care through mobile phone and digital encouragement of people to go to linkage to care, to have facility testing very close to primary healthcare facilities very close to other screening initiatives. But I think linkage to care requires a very tailored approach to really ensure that people are encouraged to go, particularly also with a link back to the community. We ran 2 or 3 years ago a very interesting project in India where we engaged with women's self-help groups who did a screening for NCDs in the community, also diabetes and hypertension. And those at risk were then referred to the facility, and then the community women groups were able to follow up with the community members. Did they actually go to the facility, and what happened at the facility? And then they were able to go through education with the people in the community to help them better understand why and how to take their medication, for example, and how to adjust their behavior that had been recommended by the doctor to not only link them to care, but also to maintain them in care and follow the advice that had been given. So I think there's a portfolio of approaches that are required. And from our side, we really think technologically there's a lot of room to move towards closing the diagnostic gap, as well as from an implementation operational approach. Yeah, and I think with this one, I would like to stop, and we'll hand over back to Guy, and we can engage in this. Thank you.
Thanks, Beatrice. Such an interesting discussion. We could discuss in the whole session. You started with it's really an ethical, moral dilemma where you started with that, of all those individuals living with hypertension or diabetes, only 50% of those are really diagnosed. And of those, you mentioned 1 in 4 only treated. Only 1 in 4 of all of those treated. This is really unacceptable. And I think it's really, this is using the example of a disease area that has very low cost diagnostics, treatments, and service delivery requirements. I wouldn't want to see the numbers on those which require more high cost support. But this is really unacceptable. I think this is one of the key areas of the pain points of our discussion going into the fourth item of meeting. How can we really access? This is one a slightly underserved pillar of the NCD response, the access issue, affordability, availability, and quality of health medicines in the product. So it's such an interesting discussion, and I think you've landed on, and certainly the issue is not only, this is not the only bottleneck. Diagnostics is not the only bottleneck. There's a whole value chain of why the different elements of the health system that are not responding adequately. But I think you've highlighted one important area that could be unblocked, which is the diagnosis, the point of care, the integrated approaches that require the necessary referral system.